So the title is Research in Youth with Chronic Conditions in Healthcare Transition. And yeah, if you can, you can scroll. I do have to declare maybe a potential conflict of interest. That is that the transition queue as a measure that I will talk about in a minute has been developed by Anne Klaassen, who is a scientist at Kenchild. And we have now licensed the tool, and it will distribute it through our Kenchild shop. The license is $50, and that is basically to help further develop the measure. And I mean, this is a first step. So it is all meant to go back to the development of the measure and to ensure the knowledge translation. Next slide. So what I want to do in the next 50 minutes or so is to give you an update on a current provincial initiative. It's called the Ontario Child Health Support Unit as part of the CHR Strategy for Patient-Oriented Research, the SPORE initiative. Here in Ontario, we were lucky that in 2015, last year, basically basically that SPORE initiative was rolling out, and they were looking for demonstration projects. And transition was considered to be a very relevant topic, and we were ready to go as we just had developed the measure to see if we could do it together in the province of Ontario. And I want to put out some ideas that I have in terms of that could inform a research agenda, basically more as just to get us started, not that I am saying what to do. And again, coast to coast, and I hear a lot of people from coast to coast, so that's fantastic. The next slide is a blank. I started to include blanks to have some pauses in my presentations, and so we have time to reflect on what just has been said, or some people want to send Twitter messages while presentation. So anyway, next slide, please. So I think in this group I don't need to spend much time on why are we discussing this topic. This graph shows clearly that there's an increase of children growing up and becoming teenagers and adults with child onset conditions. The survival rate has gone up, and I think it's really the number, as there are 3 times more adults than children with chronic health conditions, that make many stakeholders very aware of the issue. I mean, the publications on transition go back since the 1970s, 1980s, but I think looking at the research agenda, we know what the problem is. We don't know what the solution is, so I think that's where we stand right now. Slide, please. And there is enough evidence that for children with child onset conditions, and that could be any chronic health condition. Mark Farrow did some good work on looking at chronic health conditions and depression, for example, and could show that although the curve of the prevalence of depression symptoms is very similar to the pattern in children with our typically developing youth, still they have a high prevalence of depressive symptoms, and the outcomes are worse, so they end up with more likelihood in terms of mental health issues with any chronic health condition, including asthma and diabetes. Next slide. And I think we have, and also as a community of practice, we have worked both locally, provincially, and now nationally on principles of transition in healthcare. For example, starting early is a well-known principle. This is an example of my own teen transition clinic, where all teenagers get a pamphlet to raise awareness early on when they are around age 12, 13, or 14, that they are not a child anymore, now a teenager, and that we are there not only to help them with the spasticity, but also to help prepare for an adult life. And I know that there are many other good examples of that, implementing that principle. Next slide, please. So what are then the issues? I think even though we start early and we are are more aware and helping youth and families. Overall, we can say that many youth are still not transition ready at that point of age, age 18 typically, or in Ontario, I must say it's relatively strict, given the mandate of the Ministry of Health. We have to transfer the youth from the pediatric service to the adult services. Some systems have a little bit more flexibility, but still there is a system-driven transfer point. It's not individual and needs-based. And then, of course, after that transfer, I think overall, and it's not a criticism, but it's a reality, I think, that it's hard to navigate the complex adult healthcare system. And we know from families and youth that they feel lost and are not as well as equipped as we would like to see them. Despite some new work, and including our own study that I refer to, the TRACE study, I think overall we have very little in hands in terms of evidence-based information, what works and what doesn't work, and we really need to look into evaluations of interventions that would improve the transition process, and in particular also has an impact on the outcomes. Next slide. So on that note, the whole notion of transition readiness, which is a huge question in itself, we attempted to build off the work that NCLASA had done with the oncology group to broaden it and to develop with the more generic scale for self-management skills in healthcare. That is not to say that there are many other life domains that are relevant to youth, but we were looking for a very relative short questionnaire self-report by the youth that would be both reliable and valid, so that we could actually have a good assessment of transition readiness in healthcare transition. So that resulted in a homegrown tool called now the Transition Queue that was developed here at McMaster Children's Hospital and tested in over 300 youth in the age range 12 to age 18 with the various conditions. And it's a little bit small, but basically it's a 14-item scale with the 3 answering options, and the items all start with an activity. Basically, for example, the easiest item, ranked in order from easy to most difficult, is I answer doctors' or nurses' questions, and to the most difficult is that I book my own doctor's appointment. And this is the scaling, the ranking is based by the data that we have received and through a statistical method called RASH analysis. This was both confirmed in terms of the construct, so that all these items are contributing to the construct of self-management in healthcare, as well as that they are all having a different contribution to the overall score, as well as ranking from the easiest item to the most difficult item. And this morning I actually had one 14-year-old boy with cerebral palsy. He is non-verbal, who asked or was participating in our transition study, and his mom filled it out for him because he couldn't do it himself, but he did. He scored, and on the first item I answered doctors or nurses' questions as a sometimes, and I think it was really fair that the mom did give him credit for that ability, because he does in his own way respond and does help me understand sometimes what his preferences are or how he is doing. So although he is, of course, in other aspects very limited in healthcare transition, I think that the tool, even at a very minimal level, does allow for some response. Next slide, please. So this was the sample in the development and validation study that NCLASA led. at McMaster Children's Hospital. As you can see, there were both boys and girls, male and female representation, fairly equal distributed for the various clinics except eating disorder, because that's most prevalent in female. You can see also that although we have had quite a range, good sample from a range of clinics, a representation of youth with developmental conditions and more cognitive impairments was relatively underrepresented. As well, there are other conditions missing. Next slide, please. We came to the conclusion that based on the information we have to date, is that it is a short, clinically meaningful and psychometrically sound scale for the population under study. And we felt that it was fair enough to say that it can now be used in research and clinical practice to help evaluate readiness for transition in adolescents age 12 and older. The sample was age 12 up to 18, but we could also see that there was no ceiling effect. So on average, the 18-year-olds in the sample did not all reach their maximum score. So a colorful slide, maybe a pause just to reflect and to see if there are any questions before I move on so far. Okay, let me move on to what we are currently doing. So the Sport Initiative has led to the creation of another acronym. It's called the OSHU, the Osteria Child Health Support Unit. And this is basically information that I took from the website. The link, the URL is there. And the initiative is that it's really to support researchers to build clinical research capacity in child health in Ontario. And it has a nice logo and a nice tagline. We can't disagree with that. So next slide, please. As I said earlier, the Oxy Initiative is rolling out at the moment. There are different components to it. For example, support in terms of statistical support and a network of coordinators at each pediatric academic health center. And there was also funding for 2 or 3 demonstration projects, and we were very, I think, blessed by the timing, because at the time that they were looking for a demonstration project, we were ready to roll out an initiative to see if we could work together as the 6 pediatric health centers. So it's called the Transition Study, Teens Reaching Adulthood, Needs and Support for Improved Transitional Care in Ontario. And the overarching goals are to identify and understand transition gaps and issues, and in particular to include various stakeholder perspectives, in particular the youth and the families, as that fits with the SPORE mandate, to build a provincial transition research agenda, and as a very concrete project, something that we felt was relatively easy to do and feasible within the time frame of the 2-year funding portfolio to roll out transition queues, so to other sites. Next slide. So the first thing we did was to bring together this different various stakeholders. That was held in November last year, and there's a full report available, but I think the most important thing what we did was bringing together and creating that momentum, that we really felt that a collaborative approach is needed to move the research agenda forward. I think that was the best outcome of that day. Next slide, please. So to get a better understanding what is happening already, we started an environmental scan, and that has been shared with the community of practice. Julia Haynes, student assistant, has shared that, and everyone, I want to take the opportunity to thank everyone who has sent feedback already, because it's ongoing in Ontario and beyond. But within Ontario alone, we determined 28 transition programs. If you look at the bigger picture, predominantly with the condition and or center-specific focus. And also quite remarkable is that the programs are very situated in the children's hospitals with comparatively less adult provider involvement. That seems to be an ongoing theme in transition. The majority of the programs are not evaluated or evidence-based. I know some of the programs are working on it right now, but don't have it fully evaluated or published. And there is a consistent use of so-called homegrown measures, tools, checklists that may work really well for the programs. And but if you want to work towards a comparative study or something that would have some cross sites, we are looking for something that has evidence of reliability and validity. And then, of course, there is the challenge of helping the youth transition with more medically complex care needs, developmental delays and cognitive impairments, and technology dependence. That is a whole category on its own. Right. So currently we are rolling out the implementation and validation study of the transition queue. We have agreed on that. We have some clinics that are participating to see youth over age 18, which is a great opportunity up to about age 25 to also look how the transition queue will respond in youth over age 18. As you can see, we have representation of the 6 academic health sites, and it's very important that we also had interest from North York General Hospital, health program for youth, who wanted to join us, as well as other stakeholders, including the Provincial Council for Maternal and Child Health. Next slide, please. This group, by the way, with all the names, meets monthly. We did last December meeting, and it's a very energizing group, very active group, and it's great to see the things coming along. So in terms of progress to date, we have, as McMaster site, as the lead site, we have received the first REB approval, and we are now rolling out and recruiting in various clinics, including diabetes, adolescent medicine, cardiology, nephrology, and developmental clinic. And we had a sort of an anticipated number for each site, and currently, after 5 weeks, we have completed 50 out of the 75, so about 10 participants recruited per week. And so far, I can only speak from my own experiences in the developmental clinic. The responses have been very positive, also from parents and youth with more complex care needs. In terms of REB status, once the approval, we had approval from McMaster, we are now facilitating the REB process at other sites. This is just that take time and needs some local revisions and adjust. No major issues, so we are hopeful that in January we can roll it out in other sites and recruit. And as you can see, in awaiting the REB approval, the local site coordinators have reached out to various clinics, and we have a good buy-in of, and I think also if we are successful, have good representation of conditions. We're aiming for a total of 350 participants study, and hoping that we will have the data by somewhere February, March 15. Officially, our project
Actually, I'm just going to interrupt for a minute, Dr. Gorder. There's a lot of background noise, and I'm not sure where it's coming from. So if you could mute your lines, some of you, I'm not able to mute your lines. So if you could please just be aware. Sorry to interrupt, Dr. Gorder.
No problem.
Go ahead.
So if there are, or I was saying that the project is funded for 2 years. Basically, the whole issue was that while we were approved in July 2014, actually the official contract and subcontracts with OSU had to be developed, and so we are hoping that we will have an unfunded extension for another 6 months. But it should be completed by September 2016. Next slide. And then we move on to actually, this is all background, what we have done. Something I would really I'm looking forward to discuss with the community of practice how the bigger we can improve transition experiences and ensure better health and lower costs for youth with chronic conditions in the age group 12 to 18. Next slide, please. So here are some ideas that I think that we still need to address, and we hopefully can have a discussion about. And I'm also interested in where we stand Canada-wide. It's hard to, even if you look at the literature, basically then you're looking at completed projects, but in terms of, to have a good understanding where we stand in terms of work in progress, in parallel or in silos, I think that would be a great topic for the community of practice. So I think we still are in huge need to have valid and reliable measures, in particular something that would help us understand what we define as being a successful transition or an unfavorable trajectory. I also think that we still have limited knowledge of the course of healthcare transition, and there is a need for longitudinal data. In our own work looking at developmental trajectories, we could not identify many longitudinal studies across conditions in youth in the age range 12 to 25. As part of or as an outcome also of our stakeholder meeting last year, there was the thinking around that and I think it jives with my clinical observations, that if you look at the bigger group, there's a variability, and you potentially could develop a risk or a profile of youth. Some will do well anyway, some may do okay or good enough, and some are really at risk for bad outcomes. And it would be helpful to have a more systematic approach and something that would inform us clinically in terms of having some sort of risk classification system. Then, of course, I think we need to know what works and what doesn't work. I think from the TRACE study, we have learned that interventions need to be tailored and timed, and ideally integrated in the interventions. I don't believe so much in interventions that are outside of our clinical interactions. It's really the relationship you have with the youth, the healthcare provider with the youth themselves, and the youth with the parents. It's a triangulation that we talked about. And then there may be a higher level of understanding. As we know, transition is a complex care process, but hopefully we together can identify so-called active ingredients. For example, in the TRACE study, we found that individualized goal setting was a very useful way and helped the youth moving forward, and also was very concrete and could be evaluated. And everything we do, I think, should be informed by patient and family engagement activities. So whatever we will do to move the research agenda forward, we always have to look for opportunities to get their input throughout the process, from ideas up to actual studying. Next slide. And I think that's my last slide, are more specific into some thoughts around design ideas. As I mentioned earlier, I think the progress in research has been halted because of the singular diagnostic group approaches. So apps have been developed, for example, transition apps for a specific diagnosis group, to name, for example, inflammatory bowel disease, which is great, or arthritis, but how does that sort of translate to other diagnostic groups? So we may want to have a discussion about the advantages and disadvantages of a non-categorical approach versus a singular diagnostic group approach. In terms of interventions, I really like to welcome ideas around what are we thinking, what would be, where do we stand, and what would be the interventions to be tested at the moment. I think it would be useful to have a look at well-developed tools, for example, the 3-sentence summary or the My Health Passport from the Good to Go program, maybe tools that are out there, a lot of clinical expertise, and maybe have opportunities to evaluate that together. Then, of course, there are all sorts of design issues. How do you actually study those interventions with a complex care process? If you look at the funding opportunities at the moment, I see CHR and also the SPORE calling for so-called comparative effectiveness studies and very pragmatic approaches. So that may jive really well with what we are hoping to do. And then we also need to think of, right, do we compare that or contrast that with without extra transition supports, and there may be very natural variation in the level of transition support, so we need to look into stratification for potentially different sites or different jurisdictions, or even at the level of transition programs. And then last, the outcomes. I think a nice systematic review by Pryor showed the way in terms of what they call the triple aim framework. So not only to look at health outcomes, but also to evaluate the experiences, I think from both the youth and the families perspective, as well as an economic analysis. And something we have learned and want to build upon is from the TRACE study is that individualized goal setting and evaluation with the Canadian Occupational Performance Measure may be a very useful way to move forward, as well as the transition queue. If we have more information, how that so shows potentially also responsiveness may also be pick up changes in healthcare or self-management skills. So that are my thoughts. Some of them I have tried to how do you say it, lay out and as part of a foundation grant application for CHR. That was recently the phase 1 application. Unfortunately, the competition is fierce, I could say that, and I have not been invited for phase 2. So I'm looking for that doesn't. Of course, I was disappointed, but it doesn't withhold me of moving forward with these ideas and looking for collaboration and future research. So with that, I would like to thank you for the opportunity to share this and to open it up for a discussion and welcome your ideas.
Thanks, this is Lisa. Thanks a lot, Dr. Gorder. That's great. A lot of things to think about. I don't know, Kush, Mary, Gail, anybody have some thoughts out there?
Maybe just in the interest of time, we could quickly open it up to see if anybody has any pressing questions as Dr. Gorder summed up.
Are you able to hear me?
Yes.
Yeah. I just have one comment just from this last slide regarding the design. I think CHEER's to you, Jan Willem, for including in your outcome this lower cost. I think that's crucial to draw the necessary full engagement of all stakeholders that are required to really move something like this along. I think it's imperative that that be brought into the equation and to work at something that's really financially efficient as well.
Thank you.